Thank you so much once again for allowing me to be one of the speakers for this evening, along with Dr. Joshua Sabari, who I'm lucky to share a hallway with in the Cancer Center. I want to talk to you for the next few minutes about lung cancer screening and provide some background about lung cancer and why lung cancer screening is so vital, we believe, in such an important advance. So why are we talking about lung cancer? Why do we have a lung cancer awareness month? Well, lung cancer is a very important public health problem, not just in the United States, but worldwide. It is the #1 cause of cancer death in the United States. It is the major cause of cancer death worldwide. Until relatively recently, the majority of patients presented in advanced stages, and this means that it's less of a chance of being able to cure patients. And so if there's a way to get patients to present earlier in the disease, we'd have a better chance of curing them. The majority of patients present with symptoms, and that's because they're presenting in advanced stages. Most early stage lung cancers don't cause symptoms. And so if we wait till patients have symptoms, it may well be too late to offer the best chance for cure. And so it's been about a decade now, just about in 2021 will be the full decade, that lung cancer screening has been approved in the United States. And we believe that this has had a chance, or will have a chance, to dramatically improve survival in this disease. So these are some statistics from 3 years ago. And what you see at the very top are new cases of various cancers in the United States as of 2017. And what you'll see is that in terms of the numbers of cancers, lung cancer is second in men to prostate cancer, and second in women to breast cancer in terms of the frequency of cancers that arise among men and women. But among deaths from cancer, as you can see in the lower panel, lung cancer is the #1 cause of cancer-related death among both men and women. And this is a very significant problem. You can see that among men, lung cancer is almost the equivalent of the next 4 to 5 or 6 cancers all put together in terms of its impact. And historically, until about a decade ago, we had made relatively few improvements in 5-year survival. And so you can see that we're doing pretty well, at least as a decade ago, in terms of people having long-term survival for prostate cancer, thyroid cancer, skin cancer, breast cancer. But lung cancer, the 5-year survival rate as of 10 years ago was only about 17%. Now, that has improved significantly over the last few years. And there was a report recently by the federal government that showed that lung cancer survival was improving. And one of the reasons we believe it's improving is because of the implementation of lung cancer screening, so that we're catching patients at an earlier stage. Now, we do know that lung cancer is one of the cancers that has a direct relationship, not exclusively, but a direct relationship to a specific carcinogen, something that causes cancer, and that's cigarette smoking. We know that the risk of developing lung cancer if you're a smoker versus a non-smoker or never smoker is about 22 to 1, or 22 times greater. Now, that being said, we also know that 20% of women being diagnosed in the year 2020 with lung cancer are non-smokers or have a minimal distant smoking history. So smoking is important in terms of lung cancer, and we need to get people to quit smoking, but it's not the only story in lung cancer. Now, in terms of the influence of the development of lung cancer in people who have a history of smoking, the variety of factors that are important to talk about and that we as physicians and nurses and social workers should look at as we're addressing people who are at risk for lung cancer. One is the duration of smoking. So if you smoked for 2 years in your life versus 50 years, obviously the longer duration of smoking will put you at greater risk. The number of cigarettes that you smoke. So if you smoke 1 cigarette a day for 50 years versus a pack of cigarettes a day for 50 years, obviously the greater number of cigarettes will have a greater impact. The type of cigarette actually determines not only your risk for lung cancer, but the kind of lung cancer. So the change in cigarettes from unfiltered to filtered about 50 to 60 years ago, at least in the United States, has, we believe, led to a change in the type of lung cancer, more so-called adenocarcinomas than squamous cell carcinomas, are seen, in part because of the filters, which make smaller particles of smoke that are breathed into the lungs, and they get further out into the periphery of the lung, where there's a different type of cell which is affected by the carcinogens in cigarette smoke. And lastly, this is very important for people who take care of adolescents. The age of initiation of smoking is actually important. So the younger you are when you start smoking, the greater your risk of developing lung cancer later in your life, even with the same duration of smoking and the same number of cigarettes smoked. And so this is important because many of the tobacco companies in the past had directly targeted adolescents and even preteens with their ads, like the Joe Camel ads, to get kids addicted to cigarettes, to tobacco, and the nicotine in tobacco early in their lives. There are other factors that relate to the development of lung cancer. There's environmental tobacco exposure, so-called secondhand smoke. And this has been mitigated to a great degree by many of the public health laws that have minimized smoking in airplanes and buses, in public transportation, in restaurants, bars, etc. Worldwide, one of the greatest risks is air pollution, including biomass, which comes predominantly from cooking fires, cooking dung and peat in fires in enclosed dwellings in places around the world, especially in Africa, Southeast Asia, and India. Radon exposure is important in the Northeast, and those of you who've purchased a house in the Northeast, you know that many of you have to go through a radon test before you can sign your final contract to move into the new home to make sure that there isn't a significant buildup of radon in the home. Asbestos is also very important, and we think of this as being primarily in people who work as an insulator or a pipe fitter, but asbestos can be in homes and schools and buildings, and works together in a synergistic fashion to increase the risk of lung cancer together with cigarette smoking. Other industrial products such as arsenic and nickel for people who work in industry can increase risk of lung cancer. And then underlying lung diseases independently will increase the risk of lung cancer, COPD, pulmonary fibrosis, besides the relationship to smoking, can independently increase the risk of lung cancer. So about 10 years ago, it'll be 10 years ago next August, in the New England Journal of Medicine, a landmark paper was published called the National Lung Screening Trial, NLST. And this was a very large randomized study funded by the National Cancer Institute that randomized patients at high risk for lung cancer to either a yearly chest X-ray for 3 years versus a low radiation dose chest CT scan for 3 years. And they followed patients after these 3 sequential studies, either 3 X-rays or 3 CT scans, and looked to see if they developed lung cancer, if they developed complications of lung cancer, and if they died from lung cancer or from other causes. And high-risk patients were defined as being between the ages of 55 and 74, smoked greater than what are called 30 pack years, which is the equivalent of a pack of cigarettes a day for 30 years. And they're either an active smoker or quit within the past 15 years. And they had no respiratory symptoms that could be directly related to lung cancer. And the finding was really remarkable, that the reduction in lung cancer specific mortality, death specifically related to lung cancer, was 20%. And this compares incredibly favorably, for example, to the 4 to 5% reduction in breast cancer specific mortality from mammography, or the reduction in prostate cancer specific mortality from PSA screening. So this is one of the most effective cancer screens that we have to date. And it really changed the way that we manage patients at high risk for lung cancer. And you can see this pictorially in the 2 pictures to your right. On the top, you see the picture of a CAT scan section through someone's chest who was not screened for lung cancer. And at the arrow, the solid arrow, you see a rather large cancer inside the right lung. And the dotted arrow, you'll see an enlarged lymph node. So this patient was diagnosed when the cancer was already advanced. What lung cancer screening allows you to do, as I mentioned before, is to diagnose lung cancer at a much earlier stage. So at the bottom panel, you can see that there are two small dots underneath the solid arrow. This is what an early stage screen detected lung cancer would look like. And the chance of cure with surgical resection of these small areas of lung cancer is in the range of 80 to 90%. And so this is what we want to do. We want to find the high-risk groups, get them into lung cancer screening. If they're going to develop lung cancer, find it early before it's spread in the body and get them to curative treatment. And so at NYU, we have built across our health system a very successful multi-layered lung cancer screening program across many sites in Manhattan. Now we've initiated screening in Brooklyn. I'll talk more about that in a minute. We've collaborated with what used to be called NYU Winthrop, now called NYU Long Island's lung cancer screening program, which has been going on now for over 20 years. We have well over 450 patients, probably over 700 to 800 patients who are currently being followed. We're closely integrated with the NYU Smoking Cessation Program, which comes out of the Department of Population Health, led by Dr. Donna Shelley and Peg Riley. And we're using it as a focal point for translational research so we can learn more about why some patients who are at high risk develop lung cancer and some don't. And really, we rely upon groups from throughout the medical center at multiple sites, multiple divisions and departments that you can see here on the right, to take the lead in building this screening program. But really the heart and soul are our nurse practitioners, Peg Riley and Maya Drain, and our patient coordinators, Jackie Korea and Audrey Sorensen, who really are the heart and soul of the program. The doctors play an important role, but secondary to the nurse practitioners in terms of the day-to-day running of the program. So in terms of our expansion, we only started about 4 years ago in the Manhattan side. We rapidly grew and expanded from our central sites in our internal medicine associates practice to medical practices across the city, both NYU focused and non-NYU focused, and have expanded recently this summer to our family health centers in Brooklyn, and most recently this month to the very large Levitt practice in Brooklyn, in the Midwood section of Brooklyn. And we've been very successful at getting referrals from our Brooklyn side as well as our Manhattan side. And this goes along with our Long Island screening program, which has been very successful, as I mentioned, for 2 decades. This is a very busy slide, but what I would say is that the way we've worked this is to build it into our electronic medical record. Many of you get messages from this, from the so-called MyChart system. We've built this in so that the system knows which patients who are in the NYU system are at high risk, alerts the primary care doctors and other physicians as to which patients may benefit from lung cancer screening, and literally makes it as easy as a point and click for those doctors, the referring doctors, to send their patients into the lung cancer screening system. And we try to incorporate and make it as easy as patients are possible so that they can get their advice about screening and whether they should do it, and get their screening scans done at an NYU imaging center and get the results back in additional counseling in as expedited a fashion as possible. And we try to make it as seamless for both the patient and the referring physician as we possibly can. And then what do we do with those small little nodules? How do we know which ones are actually cancer and which ones are not? We can't and shouldn't operate on all of them. And in combination with our colleagues in thoracic surgery and interventional pulmonary, we are some of the pioneers in the country in what's called robotic bronchoscopy, with patients who are asleep, to a minimally invasive procedure to literally navigate out to the periphery of the lung to get samples done safely and efficiently from those small nodules, so we know which we can watch and which need to be removed surgically. And we are poised to be some of the national and international leaders in this novel technology for getting a minimally invasive outpatient low-risk diagnosis from the small lung nodules. But really, we are, as a lung cancer screening program, part of what is an absolutely superb multidisciplinary Perlmutter Cancer Center and a lung cancer center within the Perlmutter Cancer Center. The core programs being thoracic surgery, radiation oncology, medical oncology, and pulmonary medicine, but we coexist with the absolute best programs that we couldn't function without in pathology, to review our pathology specimens and conduct cutting-edge research, population health, as I mentioned, in smoking cessation, and helping us to implement novel programs like lung cancer screening, some of the best thoracic chest radiologists in the country who help perform our lung cancer screening as well as other procedures, and researchers in environmental health who are helping us learn more about the exposures that put people at risk for lung cancer. And this whole team together, I believe, will help us conquer lung cancer within our lung cancer program at NYU Langone. So thank you very much for your time. And I'm happy to take any questions after this is done. So thank you very much. And
Dr. Sterman, that was great. That was very informative. We appreciate it. And just a reminder, we will take questions at the end. There is the Q&A box on the right-hand side. And with that being said, I'm going to turn the program over to our medical oncologist, Dr. Joshua Sabari. And Dr. Sabari, I'm going to give you presenter rights. Let's see here.
Thank you, Rachel. Let me just pull my slides up.
Sure, thank you.
So thank you to the organizers and for having me tonight. My name is Dr. Sabari. I'm one of the thoracic medical oncologists, as Dr. Sterman had mentioned, in the Perlmutter Cancer Center. And my goal for tonight is to really talk to you about some updates in medical oncology. So these are my disclosures. So for the outline for tonight, I'm going to just go off exactly what Dr. Sterman had already mentioned. And if two folks tell you the same thing twice, two doctors, it must be important. So we'll talk a little bit about lung cancer screening. I'm going to talk about the treatment paradigm for stage 4 non-small cell lung cancer, and we'll talk about what that means. And then really focus in on some very exciting and innovative clinical trials. So this is developing the next generations of therapies. And we'll talk about two trials that are near and dear to my heart that are ongoing right now, looking at targeting EGFR mutations as well as KRAS mutations. So a huge misconception out there in the community that only smokers get lung cancer. What do you think out there, everyone listening? Is that true or false? So we all know that it's false, right? So it is more common to develop lung cancer in someone who's smoked, but actually the rate of lung cancer in those who've never smoked or smoked minimally, less than 10 pack years, is actually increasing, and more commonly seen in women and women of East Asian descent. So this is a great ad campaign that was pushed forward by the Lung Cancer Alliance, now affiliated with the Lung Cancer, I believe, Research Association, that lung cancer does not discriminate, right? All people can develop lung cancer. The only thing you need to get lung cancer is lungs. So when we think about lung cancer, right, we think about who to screen, who's at high risk. So Dr. Sterman already talked about this population, right? If you're of the age 55 to about 80 years old, depending on your insurance, and you've smoked or quit in the last 15 years for more than 30 pack years, so a pack a day for 30 years, or 15 years, 2 packs a day, you qualify for lung cancer screening, which is a low-dose CT scan. And again, we have a phenomenal program here at NYU really focusing on that, understanding and identifying lung cancer early. One of the pushes in our group, Dr. Elaine Shum, one of my colleagues, who's a thoracic medical oncologist, is actually interested also in studying patients who've never smoked, who may be at high risk of developing lung cancer. So she actually has an ongoing project that is about to open called the Female Asian Never Smoking Study, which allows young women, Asian women predominantly, to enroll in the study to get low-dose CT scans that are free, but in combination with obtaining a research blood test that may help us understand genetic alterations. So if anybody is interested in a study like this, please reach out to the Perlmutter Cancer Center or even the screening center, and they can push you in the right direction. So I really want to focus this talk on stage 4 disease, or cancer that starts in the lung and learns how to spread to other parts of the body, like the bone, for example, or the liver. And again, the best way to prevent stage 4 disease is to identify the cancer early so that it can essentially be cured. And earlier stage cancer, stage 1, stage 2, or 3, that's cancer that starts in the lung and does not spread to other parts of the body. Those cancers are curable in intent, meaning the goal for the treatment of those types of cancers are to get rid of them. However, in stage 4 cancer, we know that the cancer has already traveled to other places of the body, usually through the blood, and the goal really is to treat symptoms related to the cancer, obviously to extend life, but to have good quality of life. So the key thing here is, get tested early or screen early, because that can hopefully prevent this. And as we continue to study new therapeutics for our patients, I truly and deeply believe that the best way to eradicate this disease is smoking cessation, yes, but it's also to look for the disease early and prevent it from presenting, unfortunately, at a later stage. So when someone does have stage 4 lung cancer, lots of tests are done, CT scans, PET scans, sometimes even MRI of the brain. And this is to stage, to try to understand where the disease is in the body. And we know that when stage 4 cancer presents, we really need to think about systemic treatments, or treatments that also can go all over the body. So there are 3 major subtypes of systemic treatments for lung cancer. The first one being chemotherapy. And chemotherapy is a toxic agent that's infused in the vein and kills cancer cells, but unfortunately can also kill normal cells. The second type of therapy is called targeted therapy, and there are 2 specific subtypes. Some are called small molecules, and the way we know they're small molecules is they end in the letters IB. You might have heard of osimertinib. That's a small molecule. And some of the antibodies that we know of are ending in AB. These are larger molecules. You may have heard of bevacizumab, for example. These are targeted therapies targeting specific abnormalities in the cancer. And lastly, immunotherapy is relatively novel or new, FDA approved about 5 years ago, and these are the PD-1 or programmed death 1 or programmed death ligand 1 inhibitors, and these actually rev up the immune system to better recognize and attack cancer. And as Dr. Sterman mentioned, we've made huge successes or leaps in sort of survival, how long people live with lung cancer due to the development of these new therapies. I won't focus that much tonight on immunotherapy, but just to highlight, in folks who were smokers and have a high level of PD-L1 or programmed death ligand 1, the response rate to immunotherapy is high, and patients can live, prolonged or very long periods of time. One of the recent presentations looking at patients with this high PD-L1 expression, patients had on average 5-year survival of over 25%. So that's a huge change from where we were only 3 to 5 years ago. So where were we 5 years ago? So 5 years ago, when somebody was diagnosed with a stage 4 lung cancer, this was the treatment paradigm. You basically had chemotherapy as an option. And the first line therapy for somebody with stage 4 disease was these 3 drugs, the chemotherapy drugs. And if the disease progressed on these therapies, the second line option or the second option was another chemotherapy called docetaxel. And we've come a long way from that time. So currently in 2020, it's a lot more complicated. We have a lot better options for our patients. But that being said, docs who take care of patients with this type of cancer have to have a lot more knowledge and access to specific testing for our patients. So the key thing that I always talk about when I meet a new patient is I want them to understand what their mutation is, or why is their cancer growing? What is the driver mutation? And we do that by testing the cancer or next generation sequencing. We could do it in the blood. We can also do it in tissue from a biopsy. And it's so critical because if you identify a mutation, you can match that patient to a targeted therapy. And there are now 7 FDA-approved targets that have approved medications. Now, if somebody does not have a targetable alteration, we then look at this PD-L1 expression or programmed death ligand 1. And the way I think of PD-L1, it's the cloak or disguise on the cancer cells. If there's a high level of cloak or disguise, the immune system is not able to recognize and attack the cancer. So if we remove the cloak or disguise with specific antibodies or immunotherapies, there's a high chance that the cancer will respond to the therapy. So in patients who have a high level of cloak or disguise greater than or equal to 50%, we often offer immunotherapy alone, and pembrolizumab or Keytruda is one of the most commonly prescribed medications in non-small cell lung cancer. However, if somebody has a low PD-L1 expression or low level of cloak or disguise on the cancer cell, we need to add chemotherapy to the immunotherapy to allow the treatments to work better. So how can we identify which patients or which treatments would work best in individual patients? So this is actually one of the most exciting things in lung cancer, but in oncology in general. As we learn more about the biology of cancer, we're able to better understand why cancer started in specific patients and what mutations or abnormalities are driving the cancer. If you go back to 1999, and that's 21 years ago, we knew that KRAS mutations were relatively common, but the rest were unknown, right? We didn't know why cancer developed in these patients. And then fast forward to 2020, we now have a broader understanding of what mutations are identified in which patients. So this is from a study from 2017 where we sequenced over 1,000 patients, meaning we got a piece of the tissue and did specific genetic testing. And the genetic testing that we're looking for is not things that are inherited from mom and dad and one has a risk of passing on to their children. We call those germline mutations. That's not what we're looking for. What we're looking for are called somatic alterations. These are alterations that are acquired from the environment. Could be from smoking, but also could be from radon exposure, pollution, or other things that we're not aware of at the moment. So when you look at this pie chart, this is showing us the distribution of the different mutations seen in different patients. So right off the bat, we know that KRAS mutations are common, about 25% of patients, but EGFR mutations are also very common. Now, imagine you were a patient with a specific mutation. Let's pick ALK, ALK fusion. You would benefit from an ALK or ALK inhibitor. So really personalizing medicines to individual patients is critical. And in 2020, there's only about 10 to 15% of patients where we can't identify a driver alteration. Now, not all drivers have active therapies available, and that's why we're doing a lot of research in this field to try to better allow therapies to be available for our patients. So why does biomarker testing upfront matter? This is a very common scenario that I encounter in the office, and it's difficult. We have patients who present with symptoms, shortness of breath or cough. They're scared, they're newly diagnosed with lung cancer, and they say, "Doc, can we start treatment yesterday?" And how do we respond to those patients? What I say is, let's wait for the results of your biomarker testing. I want to start the best possible treatment for you as soon as we can. Now, if somebody can't wait, we can start chemotherapy and wait till we get the information back. But I generally do not start immunotherapy until I make sure that I understand what mutation or what driver the patient has. Remember, again, there are multiple mutations, 7 that have FDA-approved therapies, and another 4 or 5 that are currently being actively investigated in clinical trials. So if somebody has a specific mutation, we're going to match them to that specific therapy. It's often funny in the office when I talk about the 3 different types of treatments, the infusions or the pills, every single patient says to me, okay, how do I get on the pills? And really the pills are really based on what we identify in the genetics. So focusing in on target therapy, I wanted to highlight 2 clinical trials that are currently ongoing at NYU. So the first trial is a compound called JNJ372. It now has a name called amivantamab. And just to put this trial into perspective, we just showed that there are multiple different mutations that can occur in cancers. EGFR, or epidermal growth factor receptor, it's a gene that regulates how cells grow and divide. And when it's abnormal or mutated, it can lead to constitutive or ongoing continuous activation of cancer cell growth. So we know that these are relatively common, and lots of work has been done to try to block them. So EGFR exon 19 or exon 21 are common mutations, and we're very successful at inhibiting them with early generation inhibitors. These are IBs or oral therapies. On average, patients were able to take these medicines for about 12 months, and then unfortunately, the cancer outsmarted the pill, and patients would develop what we call a secondary resistance mutation, or another mutation in that same gene that made that pill no longer effective. And we then developed a 3rd generation inhibitor called osimertinib or Tagrisso, which worked better than 1st generation inhibitors. And unfortunately, we are still seeing resistance develop to the third generation inhibitor. So this study really looks at that population where there are no other targeted therapies available. If we identify a specific abnormality, can we then match patients to the targeted therapy that's available? So this is a patient of mine who, again, had an EGFR L858R mutation, which is a relatively common mutation in EGFR, and was on a first generation or early inhibitor for about 9 months, and unfortunately developed progression or growth of the cancer. And we identified by doing a liquid biopsy and a tissue biopsy, this T790M. And by identifying that, the patient was able to then go on to osimertinib, a third generation inhibitor. The patient was on the drug for about 2 years and unfortunately again developed progression of disease. When we then sequenced the patient's tumor, we identified this C797S, which occurs in about 15 to perhaps 20% of patients. And because they had that mutation, we were able to match them to this drug, JNJ372. And what we're looking at here are cross-sections of the patient's abdomen at baseline. You see with the pink arrow, there's a tumor in the patient's adrenal gland measuring 6 by 4 centimeters. And over time, over a course of 6 to 8 to 12 weeks, there was a 68% reduction in the tumor size. And this patient was on therapy for quite a long time, over a year, but unfortunately also had progression of disease and is currently on chemotherapy. I want to shift gears and talk about a different type of mutation. This is the KRAS mutation. Interestingly, KRAS mutations are more commonly seen in smokers than never smokers. So again, this idea of only sequencing or doing biomarker testing in our never smokers is not true. We should get testing in all of our patients. So KRAS, we said, was 25% of the patient population, and we've had very difficult time targeting KRAS. Historically, there have been 35, 40 trials looking to target KRAS, all of which have been negative. It wasn't until about 5 or 6 years ago where we better understood that there were multiple subtypes of KRAS that we were able to develop targeted strategies for this mutation. So for KRAS G12C, that's one of the most common KRAS mutations, makes up about 14% of all non-small cell lung cancer. Or if you look at the KRAS group of patients, it makes up about 35 to 40% of that group. We now have a therapeutic strategy available. So there are 2 ongoing clinical trials now at NYU with a compound from Mirati Therapeutics called MRTX849, as well as Amgen or AMG510. And I want to show you some of the updated data that was presented actually about 3 or 4 weeks ago now from the Mirati compound, now called adagrasib. These drugs all have sort of pharmaceutical names with numbers while they're being developed, but once they have initial success in patients, they then develop a name and hopefully move on to approval so all patients can benefit from them. So what we're looking at here is something called a waterfall plot. So each one of these bars is an individual patient. So an upgoing bar is the tumor growing, and a downgoing bar is the tumor shrinking or regressing. And you can see that there's a scale here of 40, 20, 0, minus 20. This is the degree to which the tumor regressed in size. So most patients who received this therapy had regression in the cancer. So this is a really effective strategy for our patients. We're still looking at different combinations, but again, I advise all patients who have lung cancer to make sure that they ask their physician, their doctor, what is my mutation? If standard therapies are not working or stop working, maybe there's a clinical trial available for me that I can benefit from. So this is a patient who was on the KRAS study, the G12C study, and you can see at baseline, this is the cross-section again of the patient's lungs, and you can see that the lungs look replaced by dark soft tissue metastases or lung nodules. And after 9 weeks of receiving therapy, patient had a 60% reduction in the size of the tumor. So improvement in their respiratory status, improvement in their cough. and hopefully we'll see a benefit in their survival as well. So I just want to end with a couple take-home points that non-small cell lung cancer is not one disease. Therapy should be directed by what type of cancer somebody has. It should be directed by what type of mutation somebody has. And if we don't identify a mutation, then looking at the PD-L1 expression to help guide whether immunotherapy alone is effective or whether immunotherapy needs to be used in combination with chemotherapy. And again, making that point that molecular profiling or biomarker testing is critical, regardless of what type of lung cancer, regardless of smoking history, and regardless of what patient characteristics. So all patients should have this testing done. And systemic therapy is very active in non-small cell lung cancer. We talked about 3 types of systemic therapy: chemotherapy, which again is very active and oftentimes necessary in lots of patients, targeted therapy, and immunotherapy. So I'll end here, and really we'll have questions at the end of the break. But again, I want to thank everyone for their attention. I want to thank our patients and our group here at the Perlmutter Cancer Center for being phenomenal colleagues, but also for dedicating their lives to this disease and to treatment of our patients. Thank you for your time.
Dr. Sabari, that was great. We really appreciate you being here tonight. All right, moving on, I would like to give permission to our next speaker, Catherine Paykin, who is a senior social worker here at Perlmutter Cancer Center. All right. All right, Catherine, you now have permission and you are unmuted.
Okay. Hi. It's a real privilege for me to be here on this panel. And Dr. Sabari, I love that last slide you showed of the team, because to work with Dr. Sterman, you, Dr. Sabari, and the rest of the team is truly an honor, as well as working with my patients and families. They are amazing, amazing people that I learn from every day. And tonight I want to tell you, and I'm going to share. See. Tonight, I want to tell you about 2 spectacular lung cancer awareness events in 2020 that the Living with Lung Cancer Support Group and the Caregiver Support Group spearheaded, along with me and Dr. Shishua and Dr. Sabari. And yes, this first photograph, which will lead into Kites for a Cure, is pre-pandemic, but I thought it catched the spirit of the Kites for a Cure program. But first, I'm going to tell you about the second program. This year, the patients and families and staff took a virtual visit to Capitol Hill in Washington, D.C. with the GO2 Foundation to advocate for lung cancer research funding to be increased back to the original $40 million. It had shrunk to $20 million. And it's in the Department of Defense, which I didn't know, but apparently it's there, this money, for government research on lung cancer, because the military is also very particularly at risk for lung cancer. We met with staff from Senator Schumer's office, Gillibrand's office, Representative Carolyn Mulroney, and many others. And the staffers just listened to us. And I was so proud as people living with lung cancer told their story and were heard. And it was a very, very successful visit. And the GO2 Foundation is launching other advocacy opportunities as well, focusing particularly on screening. And all of this attention is important because it can help people get screened earlier too, by showing that it's okay. It's not, nobody wants this diagnosis, but to find out sooner is the better. Now, the second event was Kites for a Cure, where we partnered with the Lung Cancer Research Foundation. And this photo here is of a kite festival, an international kite festival in Austin, Texas, pre-pandemic. But during the pandemic, what we did is often the people that took up the challenge to fly a kite to show promotion of the need for lung cancer research, did it with family or on their own. And with great pride, let me show you some of our heroes. This is the program. It was August 30th. And that's me at Taptree State Park in Long Island with my rainbow kite. One of our Long Island staffers from Long Island Perlmutter Cancer Center. And one of our Brooklyn, my colleague, the social worker that facilitates the caregiver group on her child. A physical therapist from East 38th Street. Here the whole family's involved. And this takes us to the shores of New York, to New Mexico, and upstate New York. A clinical trial promoter, Upper West Sider. Coney Island, Vermont. Queens. Back to Coney Island. And back to Austin, Texas. So we welcome these activities and the participation, and a special thank you to Dr. Shashua, who spearheaded this kite flying program that we have. And it's really with great pride now I want to I'll be introducing you to two people. First, Sean Ulibarri, who is a member of our caregiver group, is going to talk about, as a friend, being a caregiver. And following him, we're going to return to Leo, one of our members of our Living with Lung Cancer group, who will talk to you about his experience. Thank you so very much.
Okay.
Hi, Sean. We're delighted to have you join us today. So you take it away.
Hey, Dr. Sabari. Hey, guys. Thanks, Catherine. Oh, gosh. A few months ago, I rushed back to New York from my family ranch in Wyoming when my best friend of 30 plus years, Joe, told me he had stage 4 lung cancer. Joe managed my business and my ADHD life in New York. He started getting sick about the same time COVID hit us in March. Admitted to the NYU Longhorn ICU for about a month in June. We found that the cancer spread from his lungs, liver, bones, and brain. At the ICU, Joe improved, and to my delight, instead of dying like we thought he would and I feared, Joe began a drug therapy and now is thriving. The drug attacks the cancer at a genetic level and stops it from spreading. From not being able to get out of bed, walk, or keep food down, Joe is now doing so much better. Today, Joe is able to take care of himself, give himself his shots, medication, go for walks and shopping, and he does his own cooking. He is so much better, but has a long way to go. Since the cancer diagnosis, he lost about 45 pounds, which he needs to gain back. As Joe's healthcare proxy, I cook with him, we eat together, laugh, listen to 80s music, and even dance around when I go visit. Yet, I take nothing for granted. Life is fragile and to be treasured. My time spent as a healthcare proxy agent and part of a caregivers group have been very meaningful to me. Just listening to the group brings me a wealth of information, and being heard by others is priceless. Thank you, guys. So really grateful for this. Thanks, Catherine.
Thank you so much, Sean. It's great to hear you.
Thanks.
Okay, and that's a great lead-in about our caregiver group. We're going to turn now to Leo. And Leo, to have you share a little bit about your experience.
You're still on mute. There you go.
Okay.
Yes.
Okay, thank
Hi,
you.
Leo. Go ahead.
Okay, thank you very much, Catherine. Good evening, everyone. I'm Leo. I was diagnosed with stage 4 cancer 2 years and 8 months ago. It was very hard to accept because there was no previous sign. I was never treated with any cancer-related disease. How can I have stage 4 cancer? And from what I know is that stage 4 cancer has no cure. It's unfair. I said, how am I going? Stage 4 cancer is like a death sentence. And the only question now is, when is the execution? So I said, how in the world could that be? So I tried to think about it. And then there was one time I was inside the St. Francis Church. I was paying a visit to the Holy Sacrament, when all of a sudden, I felt numbness all over my body. I could hardly move. I could hardly breathe. I wanted to shout help. No sound came out of my mind. It's a good thing that they have a security guard there. And when the security guard saw me, he came to me, got hold of me, said, you have to go to the hospital. You don't look good. So he called for an ambulance, and the ambulance came, and the ambulance of NYU Langone. I was brought to the emergency room, and I was transferred from one bed to another. So many tests were conducted, and after that, I was brought upstairs, waiting for the diagnosis of the doctor. And they said, I have stage 4 lung cancer because I had suffered sort of a heart attack inside the church. So they said that I have stage 4 cancer because the cancer has metastasized. It has sort of spread all over my body. So I said, how can this be? It's a little unfair. Well, anyway, stage 4 cancer may be death sentence, but then you are given a little time. Now, how long? 2 months, 4 months, 1 year? What is the time for? For what? So I thought maybe I have my maximum life, that for everything that happens to you, there is a reason behind it. What could be the reason? And I tried to think of how I lived during the past 81 years, because I'm now 81 years old. And I said, there must have something happened during the course of my life. And then it dawned on me that there was a time in my life that I really lost my way. Even I was having a life that was filled with nocturnal activities. I even have sacrificed my family. I failed as a father. I failed as a husband. In short, I lost my way. So maybe now this cancer 4 has been given to me to give me time to maybe find that way again. And so I joined the Legion of Mary. And when they asked me, why are you joining the Legion of Mary? I said, I am a lost soul. I'd like to find my way again. I'd like to ask this Legion of Mary to help me find my way again. They accepted me and they offered a prayer always. Before every meeting, they would always offer a prayer and say, Mama Mary, Brother Leo is a lost soul. He wants to ask for help. He wants to find his way again. And I think I found my way. For the past 2 years and 8 months that I have been having immunotherapy, chemotherapy, Dr. Sabari is one of my oncologists. He could bear witness. For the past 2 years and 8 years, 2 years and 8 months, things have just been okay. The result of my CAT scan, the result of my brain scan, because I underwent gamma knife mega surgery, brain surgery. I've undergone robotic surgery. They bore a hole in my stomach, and they put the robot there, and the robot just did its thing. It was a very delicate operation, and I had to be hospitalized for 7 days. I was also having a mega knife mega surgery, brain surgery. I was operated noontime. I was released 5 o'clock in the afternoon. It was a successful surgery. Even my robotic surgery, although very sensitive, I was hospitalized for 7 days. But I said I found my way again, and for the past 2 years and 8 months, things have been okay. And I joined the lung cancer report group of Catherine. And Catherine has that kind of expertise that although we are all cancer patients and stage 4 of that, yet he was able to make us feel that we are ordinary, normal people. And then he asked us one time if we could possibly write an article about the experience with our cancer. And I wrote an article and I entitled it, Thank God for Giving Me Cancer. Because of cancer, I found my way again. Thank you.
Thank you so much, Leo. Thank you. Beautiful. Beautiful.
Thank you, Leo. That was great. And thank you to Sean. Thank you for both being here tonight and sharing your stories and experiences. It means so much. And Catherine, thank you for sharing the beautiful pictures of the kite flying event. It looks so lovely. And we thank you for all the hard work you do here at Perlmutter Cancer Center.
Sure.
All right. And now we have some time for questions. So if anyone has a question, feel free to write it in the question box. We do have a couple questions here. We have one about, one about screening. For screening tests of early lung cancer, do you use liquid biopsy to complement CT scans? Do you use the cancer seq panels from Johns Hopkins or other research companies?
I'll take a stab at that initially, and then I'll pass it on to Josh to specifically talk about liquid biopsy and its role. No, lung cancer screening right now, the standard clinical approach to lung cancer screening, because it is an approved clinical approach, is all about low dose CT scans. It's an imaging study. So we currently don't have any other correlate as part of routine standard of care, clinical care, to do lung cancer screening. There are, however, innumerable, many ongoing here at NYU, research opportunities to combine lung cancer screening with other opportunities to try to hone down on who needs to be screened, or what do we do with the small nodules that are found that the majority of them don't turn out to be cancerous. How can we decide who to be aggressive on, who not to be aggressive on? So we're really interested in developing these opportunities, and I'll pass you on to Dr. Sabari, who can talk about liquid biopsy and what its role is and what its role is not, although it may be in the future.
Yeah, so I agree with Dr. Sterman. The standard of care currently for lung cancer screening is a low-dose CT scan. But as everybody at NYU and everybody who treats patients with lung cancer, we want to do better. We want to do more. How can we better optimize the identification of nodules? Maybe preventing the unnecessary biopsy or surgery for nodules that may not be potentially high risk. So we are working with multiple companies, biotechnology companies in this space, looking at liquid biopsy. And what is liquid biopsy? Liquid biopsy is a blood test that then looks at genetic alterations or circulating tumor DNA in the blood to try to understand if there are any sort of mutations there. Now, one of the hard things about liquid biopsy in early stage cancers or patients who have lung nodules and may not even have an invasive cancer yet is that we're not that great at identifying this tumor DNA in the blood. So we've worked with lots of different companies to sort of maximize how we can test for early cancer signals in the blood. So it's a great question. As Dr. Sterman mentioned, we have 2 ongoing studies at the moment. One that I highlighted from Dr. Elaine Shum, my colleague, where we're doing a liquid biopsy in combination with a company called Delphi, D-E-L-P-H-I. I apologize, D-E-L-F-I. They'd be upset with me, which is a fragmentation assay. In English, different size DNA fragments are seen in cancer cells and in normal cells. And this assay allows us to better understand that. So a very interesting area of research.
Okay, thank you both. We have another question here. I would be interested in hearing about the FDA-approved targeted RET fusion therapies, which you listed in your chart. How successful and what are the severity of the side effects?
So RET is a rare mutation or fusion in non-small cell lung cancer. It occurs in about 1% to 2% of patients, more commonly in patients who've never smoked. We this year saw the approval of 2 RET-specific inhibitors, selpercatinib and pralsetinib. These are both drugs that have approval now. The average time that folks are on these medicines is on the 2 to 3 year time range, and unfortunately develop resistance. Some folks are on the medicines for a lot shorter, and other folks are on the medicines a lot longer. So lots of work in trying to understand why some folks benefit more than others. Patients do develop what we call acquired resistance, or again, the cancer cells outsmarting the medications. There's a really interesting clinical trial ongoing looking at a compound called TPX00046, or Turning Point Therapeutics, to address some of the resistance mutations that occur from these 2 medicines we had talked about. These medicines are relatively well tolerated. Some of the side effects that we have seen have included things like mouth sores, have included things like lowering of the blood counts, and changing the liver test somewhat when we check blood tests. But these are all things that can be managed with your physician. But a very exciting and interesting space at the moment.
Great. Next question, are there any clinical trials available for patients with NSCLC, adenocarcinoma, stage 4, with an EGFR20 mutation? What treatment options are available for these types of patients?
So this is also an area where we do not have any FDA-approved therapies at the moment. We talked about EGFR 19, exon 19, and exon 21. Those are the locations in the gene where the abnormality occurred. For exon 20, the standard of care at the moment is chemotherapy. But there are over 9 or even 10 now clinical trials ongoing looking at targeting EGFR exon 20. We have 3 open at NYU that we're leading. So poziotinib is a small molecule that inhibits EGFR exon 20. We have another compound that the study just opened from Cullinan Oncology, CLN-081. My colleague, Dr. Vamsidar Belchetti, who directs the Thoracic Medical Oncology Group, is leading that study. And then the third compound we mentioned, the JNJ372, has very robust activity in EGFR exon 20, and I'm leading that study as well. Now, in the New York area, there are multiple centers, phenomenal centers that have EGFR exon 20 mutation studies. So I highly encourage you to reach out to your medical oncologist to discuss these.
Thank you, Dr. Sabari. Catherine, I have a question here for you. Someone is interested in joining a caregivers group. They're a proxy and a caregiver for a patient with adenocarcinoma, and they'd like to know how to join. Catherine, you still there?
I'll speak for Catherine if she's not there. My hat's off to Catherine in the sense that every single one of my new patients, I recommend that they reach out and meet Catherine. She envelops them, hugs them. I know now it's virtually. There's support. You're there, Catherine?
Yeah.
Speak
I
for
took me a
yourself.
while to get off mute, but thank you for those kind words. And I'm thinking about, Kat, why don't you, I guess email me? That may be the best way. And should I just give my email, Rachel, or is there a better way to do it?
You know what? Why don't you send the email? I can connect you both to the cancer, the community outreach email, which is cancerevent at nyulangone.org, and I'll connect you.
Right. And actually, my colleague Audrey is actually facilitating the group now, so I'll send her email, or I'll talk to her. We'll figure out the best way to get in touch, okay?
Okay. And I just want to repeat the email address one more time just to make sure that they heard the email. It's cancerevent at nyulangone.org. Next question is about clinical trials. Are there any clinical trials available for patients with, with the NSCLC adenocarcinoma? Let's see, I know you talked about that. I'm sorry, let's see.
I see a question here on KRAS G13C, which is a different KRAS mutation. Unfortunately, we don't have any great clinical trials open. There are preclinical molecules that are being studied in the lab to target G13C. Actually, our group just developed a mouse model using a biopsy from a patient with lung cancer with G13C. We implanted it in a mouse and are now growing it, and that allows us to then study novel therapeutics in an animal model to hopefully then move to the clinical trial space. There are non-specific KRAS inhibitor studies that are available, but I think that the toxicity or the side effect profile is different than using a specific inhibitor to the mutation the patient has.
Okay, we have one question here. How long does the patient typically remain on Keytruda after a successful upper lobe lobectomy? No cancer cells on scan.
So that's a difficult question. I don't know all the details, but I'll speak broadly. In patients who have no evidence of cancer or no evidence of growth of their cancer on immunotherapy, the standard recommendation is to stop the immunotherapy after 2 years. We have lots of data now showing that patients can remain off therapy without evidence of growth. However, it's a personal decision, and it's a decision that you'll make with your medical oncologist whether to continue the immunotherapy or not. It's a difficult one, right? But we don't have a great answer, but the general recommendation is to stop after 2 years.
Okay, and it looks like this last question here, are there any staff dedicated to helping patients find available trials?
So the best way to learn about trials is to talk to your medical oncologist, to talk to the team members, the nurse practitioners. Most cancer centers, most academic medical centers have clinical trial offices that list the available clinical trials. But again, I think advocating for yourself, asking the doctor, is there anything that might work better than the standard treatment currently available? Most folks think of clinical trials as a last resort. There are no other options, right? You utilize all the standard therapies. I like to think of clinical trials as, can we use the best possible therapy that'll have the best possible outcome for patients? So specifically with trials that are targeted to specific alterations, you may want to utilize those trials before using a therapy that may be non-specific, like conventional chemotherapy or immunotherapy.
Okay, and we have one more question here. What are the most common signs and symptoms of lung cancer on initial clinical presentation?
I'll let Dr. Sterman see this because I normally don't see the patients earlier on.
So thank you for this very important question. So common symptoms are symptoms that you might have from something else. So a cough, shortness of breath, chest discomfort. Those are really nonspecific, and one of the reasons why patients present often in very late stages. You can cough up blood, something called hemoptysis. That's certainly a worrisome sign, and I would say that if you're coughing up blood, you should call your primary care doctor if you don't have a diagnosis of lung cancer, your oncologist if you do, and your pulmonologists are glad to help in any case. That is one of the most concerning signs that we have, and one that requires urgent intervention. But most of the signs and symptoms that we have, cough, shortness of breath, chest discomfort, weight loss, are rather nonspecific. But if you have these and they persist, definitely go see your physician. Very important.
Okay, thank you. And that looks like that was the last question. So with that being said, I would like to thank our whole panel of speakers for being here tonight with us virtually. It was great to see everyone and hear everything that's going on and all the hard work that everyone is doing. So we thank you, and thank you to everyone who joined us. And we wish you a happy Thanksgiving. We'll see you next time.
Take care. Thanks so much for having me.
Thank you,
everyone.
bye.